We're here today in August of 2022 with Dr. Ellen Delpapa,
Yes,
perinatologist at UMass Memorial, and thank you for doing this interview.
you're welcome. I'm happy to.
Great. Well, let's sort of get into it and sort of work our way from the start. When did you decide that you wanted to be a doctor?
So this is funny because I knew when I said in kindergarten I was going to be a doctor, and I just never strayed from that path. Um,
Hmm.
Full disclosure, my parents, neither of them went to college, so it wasn't like I had doctors in the family, and I don't think people took me seriously, is what I would say. Like my parents and my friends are like, yeah. So
Hmm.
it went like that for a long time, actually. um, and then I got accepted to medical school. Like, you know what I mean? It just happened. You work.
Hmm.
You you work. You do what you think is going to be successful.
Hmm.
I would say there was a lot. I really do appreciate the people who are, they call it first generation, because it's really hard because you don't get good advice. And so there's lots of things that I would have done differently if I had had even like normal advice. And so one of the examples I give is that I was accepted to a large state university, Rutgers in New Jersey.
Yeah.
And so my parents were really happy. I was happy. But what no one knew, and like now is funny, but not really, is that I didn't apply for housing. And you had to
Hmm.
apply for housing separately. So basically, like, I don't know when we found out about it, but maybe like July before I go, or August, I realized that, yes, I am accepted to Rutgers University, but I do not have housing.
Hmm.
And that was a big problem. So I ended up being on a different campus and not having it was like a mess, right? Like it was just a mess. But like I think that somebody whose parents had gone to college, or I think somebody should have given me that advice, which was that, hey, listen, you have to apply for housing.
Well, that's a huge thing. And I actually spent 12 years on the school committee in Shrewsbury. I just came off this May. And one of my reasons is that I really think a lot of attention needs to be paid to the background of students and providing them with the services that they need, because you are absolutely right. Those sort of little details that aren't in anybody's textbook
Right.
are sometimes the difference between success and failure. And these days, if you take somebody who starts school and neither parent went to college, their chances of graduating from college are 8 or 10%, in that ballpark there. And even if they graduate from high school and start college, the finish rate in 6 years is a third. Two-thirds don't. So huge thing. You overcame it. And to me, that says that somewhere along the way, they didn't encourage you to be a doctor, but they encourage you to take yourself seriously.
Oh yeah.
They aim high.
We were supposed to be competent. We were supposed to be competent. That was I would say, my father would say, be competent. I think the real issue was a woman in medicine then, even like never
Yeah.
mind the not going to college, was they were just really worried how that would all play out in
Hmm.
what they viewed as the ideal life for a young woman. Like, I think that, to be fair, I think that's what they were worried about mostly.
Hmm.
And to be fair, also what I would say, and not this is about my parents, but they, although weren't happy, like I would say happy when I got into medical school, because they viewed it as like, oh my gosh, this is going to be really hard for you. They came around, like, you know what I mean? Like, so by the time I was like taking my boards,
Yeah.
they would come up and they would take care of my children for me while I was taking my boards. You know what I mean? Like they came around. They were flexible. They were open-minded. And when they saw that it could possibly work, I think they were on board to help.
They wanted you to be successful.
Yeah, and they love my husband. So if they didn't come to mind the kids because of me, they came to mind them because they felt like, poor Steve, how is he going to like survive two children, like, for whatever it was to get to Chicago and back again, like, you know what I mean?
Yeah.
Well,
Interesting. So what did you major in at Rutgers?
so it's a longer story. I majored in bioengineering because my father thought that I should do something other than pre-med, because suppose you don't get to go to medical school. He really viewed he
Yeah.
liked apprenticeship kind of things. But Rutgers was really not, it would have been good if I had again, like good counseling. Where I was living was Livingston campus, which I don't know if you know anything about Rutgers. It's off campus. It was meant to be a 1970s experiment that anybody who applied would be able to get into that college.
Yeah.
So the dorm was unsafe. One of my remaining college friend is a huge 6-foot man who would make sure I got home into the dorm at nighttime. Not, no romance at all. It was just that he felt like, oh my gosh, because he was from around there, and he was like, oh my gosh, this is so not good. So I transferred out of Rutgers into a small all-women's school in Morristown, New Jersey. In fact, my CV, which is funny, says Convent Station, because that is the place where the school is, because there was a train that stopped off at the convent that was where the college was. So I finished there and sort of didn't know about any, they kept on saying, no one's got into medical school from College of St. Elizabeth. I'm like, well, okay. But I did. I got in the first year I applied into a state school, to the New Jersey State School. And I think that I was well prepared. And, it seems silly now because it's so that I think, when you ask me what's changed, I mean, women in medicine are just so now it's not a big deal. In fact, it's less of a deal, I would say. But I came out, having done my own labs, having been encouraged to do research, even as an undergrad, because it was all women. And so there was really, as I always say, there was no one to hide. No one was going to hide me. So the women, I think there was, I don't know now, but then I think it all worked out for the best that I transferred out of Rutgers. Because that's just a big place. And I had come from a small town, northern New Jersey. I was not used to any kind of drugs, violence, any of that kind of stuff. And
Sure.
Tricky.
Sure. Did you go to public high school?
I did, but it was in a small suburban town. It's called Leonia, New Jersey. It's a small suburban town. I graduated with 105 people, I think.
Sure.
And I was very sheltered. I'd be the first person to say I was a sheltered high school person. It was a diverse population. I mean, so I graduated with plenty of mostly Koreans, but many Asians. There were some people of color, Black, Hispanic, but it was a protected environment. My brothers and I talk about that now too. It just all was protected. We were not exposed to the New York City that we knew was a New York City that would be you'd go visit New York City, but we didn't see the social problems of New York City. So,
and medical school, how many medical schools did you apply to?
Oh, maybe 5. You know what I mean? That was all I did. I applied. Yeah. And I got accepted to 2 of them, and took the easy way out and went to New Jersey rather than, I think Connecticut was the other school I got accepted to. Yeah. Didn't apply to, you didn't apply to all these medical schools. It's really pretty wild. But again, I didn't have a lot of good counseling. The college, again, had never had, they said never. I'm sure there'd been somebody who went to medical school after they graduated there, but they didn't have a lot of, didn't have a pre-med committee that was writing letters for you.
Right.
You pretty much had to they wrote good letters. I think they wrote very good letters because I got in. But it wasn't the factory of what I think things have become, and I think there was a factory. But so I went to medical school in Newark, New Jersey. So I went from not being able to tolerate New Brunswick, but being very able to tolerate Newark, because by then I had had enough experience, had enough you sort of grow. And so Newark was an entirely different situation. So Newark was, Newark was inner city without any of the other outer city. It was just all inner city. It was an amazing amount of drug use. And what I will say, when you asked me about being interviewed, I gave a lecture recently about HIV and pregnancy. And so the year I graduated medical school was the year that HIV was, the human immunosuppressive virus was finally was finally identified as the cause of AIDS. But I had gone through all of medical school with very wealthy gay men coming to Newark because they didn't want to get any care in New York because they didn't want anyone to know that they were gay. Sick, I'm talking sick, with the lymph nodes that were just huge, and the sarcomas, and they were just and they died. They died. And so that is like one of those things that I have lived through, I would say, and now it's like a chronic disease, right? Like HIV is like a chronic
Right.
disease. Like it's not even, it's not that it's not worth talking about, but my lecture was only 40 minutes of HIV and pregnancy because there's not that much to talk about. Like people do well, you give them medication, they get pregnant, their babies are, the vast majority of babies are fine. Internationally, it might not be true, but it is here. So that is one of those things that I think it's amazing how much has changed.
And when did you graduate from medical school?
1984.
Oh, okay.
So that was the HIV.
And what about the cost situation for both your undergraduate and your medical school?
Oh, yeah.
What kind of numbers are you?
Yeah, I think it was like, we talk about my husband talks about this because what he will tell you is that we got married when I was 30, whatever I was, like after fellowship, I was still paying loans. But I tried to explain to him, I'm not paying any of their loans compared to what other people paid for. So my college was probably around $5,000. I think that was per semester, but I didn't live there because I didn't when I Rutgers was cheaper, and so I could live there, but that wasn't the situation. So I lived at home and commuted to College of St. Elizabeth's. So I think it was like $5,000, and my parents helped me do that. But then once I went to medical school, it was all me, and the state school, as I remember, it was like $7,000 a year. So it wasn't very much, but it was, but you couldn't, I actually did work a little during medical school, which now sounds ridiculous, but I worked in a bookstore. And so I could make a little bit of money. But I took out loans for the vast majority of it. And then paid them back.
Sure.
After fellowship, right? So now you're talking about many, many years later.
So you are immersed in medical education. You have been for your entire career. Knowing what you know now regarding how medical school runs and everything, what's your impression of medical school when you went? How was the education compared to today? What do you think?
I think there's a lot less. The amount of knowledge that we knew and there, the world knew, it was so much less. Like when you think about it, like I think about all the things that I never learned in medical school because it didn't exist or we didn't know. And things like HIV, I'm saying no one knew. And so the antivirals, if there was an antiviral, maybe I learned one antiviral. And so I would say that I there's this expansion of knowledge I think is great. So I think they're expected to know so much more. I think that I was trained under what I would say a much more apprentice model. So you were on the wards, you followed somebody around, they talked to you while they were in the elevator, they talked to you, when we ate lunch. So it was much more like you were an apprentice to someone. And yes, there was lectures, but at least the clinical part of it was much more an apprenticeship, which I miss for the students because our students now just go through so much quicker, right? So I think they're up to only having really 3 weeks or 4 weeks of clinical obstetrics and gynecology. So even if I have a student with me, they're not there very long, like a week or two, and that's it. And so you don't really get that sense of a relationship with someone. Like I vividly remember the person who was the attending of my sub-I when I was a fourth year medical student, right? Because I lived with him for 6 weeks. Rounded with him, went to lunch with him, stayed late if there was a sick patient. We were just together all the time. But
you could get immersed.
You could, but I think that's different. Other differences, I think that, and I'm going to say this, I think the medical school was run by the faculty. I think now the medical school is at least halfway run by the students. So the students are, I think, more directing their own education. And I think that's because things are online. So if they don't like the lecture that was given to them on respiratory diseases, there's options of 50 lectures on respiratory disease that they can take. And now, and if their goal is mainly to pass the boards, there's probably better lectures than what the UMass faculty are giving because they're probably people who wrote the board questions and now they're giving the lectures. So I think it's a little, I think things have changed, and I don't know for the better or the worse. It's not really a judgment, I would say. It is just different.
So what do you think now? One of the things about the apprentice model is that you imitate the person who you are working with.
Yeah.
And what are your thoughts regarding critical thinking skills then versus now? Because there's a potential, at least for an upside to this new way they're doing things.
I guess I had very good mentors. And so I
Yeah.
feel like I was constantly being asked to think about why I was saying what I was saying, and what and like why. And then if I didn't know why, the answer was like, I think they taught me to think about like, okay, what do you know about this situation, and what can you apply to the question that's being asked? And so I felt like I was constantly challenged when I was in medical school. Like I really liked my medical school. Actually, it was a new medical school, so it wasn't like the old stuffy ones. It was a new medical school, and so they, so early on, I'm saying this is 1980, whatever. They had panels of gay men and maybe a gay woman, and they would, let us ask questions. Let us. They would each give a presentation about their life and what they hoped for, what they were afraid of. And I thought that like now I think like that was really pretty adventurous of them to do that. But at the time, this was the medical school that I went to. It was a pretty liberal, open-minded kind of education. I'm not so sure I speak for all of the medical schools, because then when I got out of that medical school, I realized a lot of people did not have that kind of experience. But it was good. It was good for me. But I think you do. So I find that I worry about the students not having good role models, a professional role model, right? So like what you really want is people to become professional. And I think the students, I think they struggle with that. And I think some of the residents struggle with that. And then, obviously they ultimately get there. I just think they don't get there maybe as quickly or as easily as I think. I mean, maybe for me, it was easy for me. I mean, I don't know. I enjoyed it.
At some point, you decided to go into OBGYN.
Yeah.
What drew you in, or how did that go?
This is fun. I haven't talked about this in a long time. I really wanted to be a trauma surgeon, and I love trauma. The Newark was full of trauma. It was fine. And so they did try to mentor me. And so there was one woman trauma surgeon, or maybe she was, I don't know if she ever took her boards in trauma, but she was a trauma surgeon. She was a miserable person. Like, you know what I mean? She was just so unhappy because her life was just constantly people telling her that she wasn't good enough, couldn't do it, wouldn't be able to do it. And she was like older, like maybe 10 years older than us. So she'd been out like maybe 10 years.
Yeah.
And looking around at the surgical department, I have to say it was a conscious decision of mine not to go into surgery, because I love surgery. I still love surgery. But then I went into, the joke is I was on call at a community hospital on Super Bowl Sunday. And so the attendings didn't really care if they did anything. And so they would just push me into the room and say, call us. Like if there's any trouble with the baby coming out, please call us. Yeah. And there wasn't a residency there. So it was like two of us. It was one of my friends, a male medical student, and I, who were on call that night. And we did like probably, 5 deliveries between us. Wow. And it was fun, and I loved it. So then that was sort of, I think that day, Super Bowl Sunday, whatever year it was, I said, I really like this. This would be a good choice. There was some female attendings where I was. I could see a path forward for that. I really couldn't see a path forward for the surgery thing. Yeah. And so that's when I went into OB. But I went to medical school thinking I was going to be a pediatrician. But that quickly I realized that I did not really want it. The pediatrician was the only doctor I'd ever known. And so that seemed like to be what I wanted to be. But I quickly realized I was not cut out to be a pediatrician. So I had to do something else. So then I went to MFM. And so then I went to the residency not knowing I was going to go into MFM. But then I really like sick people, hence the trauma surgery thing. Yeah. And so then the only way you can get take care of sick patients and be an obstetrician gynecologist is to go into oncology or maternal fetal medicine. Yeah. And I liked obstetrics. So that's the whole how I got to like be an MFM.
And there's a lot of internal medicine in MFM. Yeah. And so you liked internal medicine as well?
I didn't really like internal medicine when I did internal medicine. but I do like the medicine of MFM.
Yeah.
Because remember, internal medicine is a lot of chronic diseases. And so I am, hence the trauma surgeon, like anybody would tell you, like, I'm not somebody who wants to like do the longest route possible. And so obstetrics, yes, you're following someone for diabetes, but it's really only for like 9 months. And so you don't have to do it for a lifetime, because that is the hardest job. And I say that all the time, like family medicine, internal medicine, like all those chronic long-term diseases, they are really hard because people, I think they really want to do what they're supposed to do. It's really hard to live on a diabetic diet. It's really hard to do what you did, exercise, to do all the things you're supposed to do. And so
right.
I give them credit.
Yeah, I think the adherence piece is enormous with chronic illnesses, and I agree with you. I found that the diseases in internal medicine were very, very interesting, and the patients were something that would wear me down. And if I looked at obstetrics, the diseases were even more interesting, because you had this dynamic element going on, and the patients were the best they'd ever be in their whole lives. They were way motivated to do the right thing. So
diabetes, they always have the best control. Like their hemoglobin A1Cs, they're like, it's perfect. I'm like, yes, and you could do this all the time, but it's not really. So
you decided, and so where did you go for your residency?
Oh, I went to UConn St. Francis. It was a combined program in Hartford. And then I did my fellowship at Women McGee's Hospital in Pittsburgh. How
big was the residency program at UConn?
UConn was a very big program. They had 3 sites. So I was at the St. Francis site. They had, maybe it was only 2 sites then. And then they had the New Britain one. But altogether, there was probably about 8 of us, 4 at St. Francis and 4 at New Britain. And then we all went to, I don't know if you know, but there's in Farmington, there's the Dempsey is this medical school that they built in the middle of nowhere. So it's on top of this hill. And when I was there, it was surrounded by horse farms. Now it's condominiums, but it was horse farms then. So the patient population was not there. So you couldn't get enough experience if you just went to like UConn. You needed like New Britain, which is a community hospital, or St. Francis, which is more of an inner city kind of hospital. So I was UConn, St. Francis.
So there are a couple of things here. One is, it sounds to me like if we look at the dimensions of private practice, community kind of thing, clinic populations, and then research, that you had a program that was concentrated on clinical exposure, and it sounds like it was divided among clinic and community populations. Was there a lot of research going on? Were the faculty were kind of focused on delivering care?
I mean, UConn had some, but the people that I knew that were like my mentors was Vince Oleos, who did like the original BPP. That's like clinical research, right? Like, and he published. I'm not saying he didn't publish, and he published with all the fellows, and maybe some of the residents. I don't really.
Incredibly smart fellow, yes.
Yeah, he is, but he was not like a basic science research. No,
right.
He was definitely a clinical researcher. So that's the experience I had. Exactly. Yeah.
And what percent of your residency program were males or females?
Oh, there's only one other female with me.
And this is out of how many?
Yeah, I was going to say, so there would have been 16, like, so, because there's 4 years, 16.
And this would have been 1984, 1988 in that ballpark?
No, because, yes, 1984, 1988, right, exactly.
Okay, good.
So there just wasn't a lot of women.
We
had one woman faculty member, Pauline Olson, and she was just she was so supportive, and she, like, how people like are aware that they are important, and she was aware that she was important for the 2 women who were coming up on with the residents. And so she would invite us over our house, and she shared a lot of like life experiences. Like, it was like we didn't need to learn medicine from her. We just really needed to learn how to navigate the whole situation. And she was wonderful. She's just wonderful.
So with regard to the scope of practice of generalists and, when you would refer, what the availability was for subspecialists, how was that, how did that encounter during your
Yeah,
work?
so again, at St. Francis, the only subspecialist there was a maternal fetal medicine person, one maternal fetal medicine
Yeah,
person. All the rest of the subspecialties are at UConn and Dempsey.
yeah,
The oncologist, there was an REI. I mean, UConn is a big academic institution, so they had all the subspecialties even then, except for Urogyne, which wasn't a thing then.
yeah.
They had them, but they were like, for all those different sites, they might have had maybe 3 MFMs, and we're now
Mhm.
talking about probably 5,000 deliveries between all 3 places.
Yeah,
And so it was a different, and then the community hospital. I mean, St. Francis is a community hospital. It wasn't a community hospital. It was a tertiary care center. They had trauma
yeah.
there. They had a NICU there, but it wasn't the UConn, the academic site. Had a different chair.
And so when you finished your residency, did you feel what kind of exposure did you have? Did you feel you were capable as someone completing a general residency and, for example, handling diabetes in pregnancy or urinary stress incontinence or, let's say, early stage endometrial CA? Are those things that you would feel you were prepared for, or did you feel not?
Yeah, I mean, I felt like I was prepared. What I am going to say, though, is that, I was prepared because when I was a chief resident, I was the only person in the hospital. There was no attending in the hospital. So whatever came through, you were the last man, last woman. You know what I mean? They'd call you the last man. Like, you were the last person. Like, you were if the junior residents couldn't take care of it, you were the one who had to figure it out. And so, yes, the attending might come in, but I would tell you, I can count the number of times in my hand that attending ever came in the middle of the night because it was a problem with the patient. They would give you advice over the phone, but it was you. So the acute things, for sure, I was totally confident on. I would say that, was I really good about stress incontinence? I learned enough, and if I had been interested and knew that I really wanted to do urinary incontinence surgery, I could have gotten enough experience to do it all. I mean, definitely I did enough MMKs, like, you know what I mean? Like, I did enough of the surgical procedures to say that I could do all of them. I would say that my interest, by the time I was like maybe a second, third year, I knew that I was going to go into MFM. So I did a lot of ultrasounds. But yeah, I think you could have left residency knowing enough to do what I would say the first layer of any algorithm for any, infertility, for treating endometriosis, for, stress incontinence, oncology. Yeah, I mean, I feel like I could have started any of those cases. If I had come upon it, I could have started those cases and probably finished most of them. Yeah. I mean, that sounds terrible, doesn't it? But you really sort of had to be able to.
And just from a point of view of socialization, the attendings you associated with, the expectations for a career, there are terms like work-life balance. There are terms like being a professional and you are a doctor and that's who you are. There's a scope there. Can you comment on that?
All right. Well, there was no mention. In fact, it would have been viewed very negatively of any life-work balance. So, I mean, I lived across the street from the hospital in housing, and they used to say they called it a residency for a reason, right? So we rounded 7 days a week, because if you did surgery, you were expected to round on those patients.
Right.
When you say the oncologist, whatever we did, we rounded on our own. So we rounded 7 days a week. If you really wanted to take a day off, you had to ask someone to round on your patients. It was a much bigger deal. The socialization, it's hard because I was a woman and it was mostly men. It was difficult. I don't often talk about it because it doesn't help, I don't think, to how can I say, to ascribe all your problems on the basis of the fact that somebody is not being nice to you, right? Because people don't have to be nice. I guess that's like one of my father would have to say, like, life doesn't have to be fair. And so
Right.
I didn't expect it to be fair. And so I just sort of
Roll with it.
yeah, and be, and what I would say is be as competent as possible. Like that was like always my, like when I thought about things is like, I'm going to be competent. And so then if you were competent, they really couldn't bother you because you were competent, right? Like I think that
That's the credential. Sure.
Right.
And so around the second year, you decided to go into MFM, and you then moved on to McGee Women's.
Yeah.
In Pittsburgh. Big program.
Yeah. Yeah, I considered myself very privileged. Like that was the fellowship I wanted. I would say the one mentor I had is Fred Fumia, and he was the MFM at St. Francis, and he had gone to McGee Women's Hospital, and he was determined that I was going to go to McGee Women's Hospital, and there was no matching, I would say, for fellowship. It was the old boys, network of, you interviewed and then they would tell you in 2 weeks to decide what you wanted to do. Like, it wasn't like any of this, like you put a match list in. So that was very stressful. When people complain about the match, I'm like, oh, you have no clue. The fellowship was just really hard. And so I was very pleased when, it worked out that I could go to McGee. So I was interested, he was interested, and then I became interested in, like basic science research, like related to sheep and placentas. And so that was what I went to McGee to do, not really for clinical medicine, because like I had done clinical medicine. And I have to say, I love basic science research, because I think it's like the basis of all answers, and you can get such good answers. Like there's no, as I say, the rats, they're all the same. Like, you don't have to randomize rats because they're all the same, or the sheep, like they are all the same.
Right.
And so there's something very satisfying about that, I would say. Very hard to do. And I mean, the sheep research we did now is not done in the United States at all. It's done in Australia, because it just got to be so expensive and not acceptable to do here. But it was fascinating when we did it. And we learned a lot. I mean, I think that it was an NIH sponsored site that I worked with. I learned a lot. And there was, again, I think 2 fellows out of 9, well, 3, two others besides me, 3 of us. So that by now things have been like moving up a little bit. And so there's more women, I would say. So 3 out of 9 of us were women. Again, what I'm going to say is, my husband said this, they were willing to accept me as a fellow as long as you did what they wanted you to do. So when I said that I was coming back to New England to marry someone, they were really like, why would you ruin your life by moving back to, New England to marry someone? Like, it was just like one of those, like that just blew their mind. There was only one attending who like actually congratulated me, was happy for me. All the others were just like when you came here, Ellen, like basically we owned you. Like, this was not in the contract that you would, fall in love, get married, want to have children. Like, it was just not accepted. I mean, and they couldn't do anything to you, again, because you're competent and because you're doing what you're doing. But they weren't happy for you. They weren't, I mean, I don't want to make it worse than what it was. But my husband, like when we were first married, he was like, man, that was tough, because they wouldn't even like speak to him. Like when he came like to graduation and stuff, they just like thought he was like the enemy.
Jeez. So, getting back to this balance between the subspecialties and general OB.
Yeah, go ahead. That's a good question. Yeah.
You were at a phase, you were doing your fellowship, and so in that atmosphere at McGee Women's, were the generalists managing more of things that perhaps today would be managed by MFM? Did the MFM, you had said you are interested in research, and the question is, did you feel the balance was more towards research during your fellowship, and perhaps today it is a little more clinical than it was?
Definitely my fellowship was research oriented. Like they I was like a research, that's what I did mostly. I did some clinical. But see, McGee's an interesting place. I think I know it has changed a little, but there were no generalists on faculty. So the only generalists were those in private practice.
Mm-hmm.
So they did full scope everything. I mean, and
Mm-hmm.
that was always, that town and gown kind of thing. There was
Yeah.
always a lot of conflict about that because I think they felt like they could do everything. And I think they
Mm-hmm.
probably, most of the time they were correct. But I
Mm-hmm.
think as far as, I think the subspecialist felt like they had to be, they needed something to do. And so I think
Sure.
a lot of it was just, it was just that town and gown. I don't know how else to say it. Like,
Yeah.
the gown thought that they were better and the town thought that they could do everything fine too.
Yeah.
And in my experience, though, because now I really only know OB, I would say they could, they didn't really need MFM. I mean, maybe like for like the occasional RH sensitized patient, like they wouldn't do the Liley graft thing, but other than that, they could do almost anything.
Yeah. And what did you do your research in?
Well, research was trying to figure out if we could find a growth factor for placentas for fetal growth restricted fetuses.
Mm-hmm.
So, I mean, it seems so basic now, but we were like trying to find reasons that would make. So we bled sheep, made them so anemic that we thought for sure the fetus would not be able to grow.
Mm-hmm.
And then we were looking at the placenta to see if we could find some kind of growth factors, because this was like when there was a lot of oncology research about growth, like growth factors, tumor growth factors. And I'm going to say it never worked. What we did prove, though, is a lot of the shunting research came from McGee. So because we did radioactive microspheres to different organ systems, and we could tell that when the mother was made anemic and the fetus that therefore had less oxygen delivered to it through the umbilical cord, that they immediately they shunted to the brain and they contracted the liver and the extremities kind of thing, which now everybody knows, but back then people thought that the fetus couldn't control any of its blood supply, which is absolutely not true. But we never found the growth. Even now I think about it, like we really don't know how to make a placenta that has not implanted well. We cannot reverse that once it's happened. And it was sort of related to preeclampsia. I mean, preeclampsia was like the side kind of thing.
Sure.
That is like the ultimate of the placenta not working. And we never found none of the tumor growth factors could we ever use. Did it ever work? Did we ever find them when we weren't using them? Because we put tumor growth factors in, and we also like looked for tumor growth factors when we were making these sheep anemic. Never did. But we learned a lot about other things, I would say, about how that the baby's shunting.
Okay.
That's what I did. Yeah. I mean, it was fascinating. But it's very satisfying, right? Because you knew exactly what the crit was of the sheep. You knew exactly how much the babies, how much the fetuses weigh. You knew exactly like how much oxygen or how much blood supply each brain had compared to the liver. It was very satisfying.
Nice. And so at some point you decided you were going to be completing your fellowship, and you moved up to us.
Yeah, I think you probably know this story, which is that Dan Edelstone, which is the person that I did my sheep research with, graduated residency with Karen Green. Mm-hmm. So he was one of these really quirky kind of people. So I have to say, I mean, I don't know how much personally with this, but one of the faculty members, every time he sees me at a meeting, and he still is sort of half seeing me at meetings, says, "You are an odd duck, Ellen." That's all he kept saying, "You're an odd duck." And so Edelstone, instead of just saying you're an odd duck and shaking his head, would say you're an odd duck and like sort of accept that I was an odd duck. And I was an odd duck because I liked what I did and I didn't really have a big plan to not do clinical medicine. I liked it. Is that you would love Dr. Karen Green. And so I think you should work for Karen Green. So he called Karen Green, who then called me, who then I came to Worcester. And the rest is like 30 years later, like I saw her.
It was a good job.
The day before yesterday, right? The day before yesterday, I saw her at her lake house, right? So we remained friends forever. We practiced medicine happily for 25 years until she retired. But it was like an arranged marriage. That's what I say, how I ended up here.
Okay. Well, a good arranged marriage. And also, though, would you say that this is a more clinical MFM position than other academic centers? Or do you feel at any point that you're pressured to do research or anything like that? Or how's it worked out from a point of view of that balance? And yeah,
I think like when I graduated fellowship, either you did clinical or you did research. There wasn't this combination of things. I think
yeah,
particularly the research I did, like either you work in a lab or you don't work in a lab. I don't think people
yeah,
were like trying to do both. I think that that's probably not many people did that. So I think that once I came here, I knew it was going to be a clinical job. And I would say the pressure to do research is actually more recent, I would say, but that's a good pressure because we have a fellowship now. And so the fellowship requires that we do research.
yeah.
And so that's the pressure. I would also say that, when I came, it was only three of us. It was Manny, Ojimo, Karen, and I. And so even if we wanted to do research, or even if they pressured us to do research,
Yeah.
there wasn't enough of us.
Card was full. Yeah.
There was not enough of us to do that.
And again, if we look at the changes that have occurred in MFM during your career, how would you categorize that?
Well, for MFM, I would say it's just more exposure. Like when I first went into MFM, I would say the vast majority of people, even in medicine, didn't know what maternal fetal medicine people did. And even when Karen and I were first here, like we would find that the people at university campus wouldn't even know that there was a maternal fetal medicine division here. They wouldn't know what we would do, what we could do. It was just really not very visible. I think we weren't very visible at all. It was a new, because I think the first people who were like passed their boards in maternal fetal medicine were around the time that I was in residency, so like 1980 or so. There were some people grandfathered in before then, but it really wasn't a subspecialty. So I think it was just coming up. So I think now MFM, like newspapers call to talk to a maternal fetal medicine person when something happens. And so I think there's just this general idea of high risk pregnancies. Which I think is makes maternal fetal medicine different. So I think we have a much more public kind of role. I think that MFM has changed to be a lot more algorithm driven, and whether that's good or bad, there's both sides to that story. But the SMFM, our organizations, ACOG, are producing these algorithms that people follow. But I think it brings the MFM into daylight more about what we do and what we can and cannot do. So that's what I did. The changes I think are the biggest changes. I would say many more sick people with chronic health conditions get pregnant, either on purpose or maybe not so much on purpose. And so I feel like the patient population has gotten a lot sicker and obese, which I think you can't ignore, honestly, as far as the difficulty in taking care of patients. So I think those are the changes. Sadly, I mean, I've said this before in whatever article I wrote, which is that we still do not know the cause of preeclampsia, and we still don't know how to treat preterm labor. I think that's what I would, when I was graduating fellowship, I would have said for sure by the time I was in this part of my career, we would have figured out more about preeclampsia, but we have not.
So early in your career, perhaps during your fellowship, what would you say the top maternal conditions that you treated were?
It was severe preeclampsia.
Yeah.
I would say it was multiples, because remember back then the IVF people could put in as many babies as they wanted. Yeah. And so I think that took us a lot. And then at McGee, we did do a lot of RH disease because we were like the referral center for isoimmunization for the entire practice. So I would say those things, it was, so what I'm getting at, and I think what you're getting at, it was not fetal diagnosis. It was not ultrasound. It was not, the diabetes care, I'm going to tell you, like you said, the generalists took care of the diabetics, and we only saw the ones that were, had vascular disease perhaps, or, were very ill, or their babies were small and they had other problems, like somebody with an anomaly, if they could figure it out. But the fetal diagnosis was much, much less than what we do now. So like now I probably do 50% fetal diagnosis and 50% maternal disease. And back then it was like 90% maternal disease and very little fetal disease, because the ultrasound machines weren't that good. I think people weren't asking for us they weren't asking us to diagnose all their fetal conditions. So it's just different.
And when you did your training, that was roughly when alpha-fetoprotein came in.
Yeah, I witnessed
And,
that. Yeah.
so you bring up an important point, which is the tools for diagnosis have changed substantially. There was, I guess early in your career, probably no alpha-fetoprotein testing done for anything. Then it came in just for neural tube defects and then the relationship with Down syndrome. And then, the issues of maternal blood with the fetal cells in the blood and genetic diagnosis there.
That's a big, that has changed MFM. Like, I think the people you're going to interview 30 years from now are going to talk about the fact that cell-free fetal DNA changed the entire practice of maternal fetal medicine, because now we're using it for a very narrow use, but we will soon be able to, I think, diagnose cystic fibrosis, like almost all the things that we need to do now invasive testing on cell-free fetal DNA, which is fascinating because it gives people more options. Like I never, the conversation of deciding to do an amnio with the risk of spontaneous abortion and miscarriage, or not knowing if your child had, say Down syndrome, that's a really difficult decision, and value, like the morals of that are just really difficult. And now I think it makes it so much easier just for people to know, and then they can decide what they want. And then, so that's a different decision, and that's not any easier, but at least they can know. So I feel like that's been a big, the fact that it's made it easier for me doesn't really matter, but it makes it easier for the patient, because I'm not constantly in this kind of dilemma of, yes, it could cause a miscarriage, but yet do you want to know?
Okay.
That's hard.
And with regard to counseling, one of the things about your field is that you're in a position of counseling people regarding pregnancy, continuation, and the like, and it requires a particular skill set and sensitivity. Yeah.
And so I know you're not going to ask me, but in a million years, I never thought that Roe would ever be overturned. Like when never thought, in recent year, I have thought maybe perhaps, I do read the paper, but I meant like if you had told me, so one of the attendings that I had an apprenticeship of he was from Argentina, and he would discuss about what Argentina without abortion looked like, and how it would be like dying on the street because somebody would have had to do an illegal abortion, and then they were fearful that they were going to find out that this patient was going to die, so they basically would drop them off at some corner of a street, which was horrific to us, because even then there was abortion care, but the fact that we're now in a post,
the debate is up there.
It's just amazing, because I vividly remember him talking to us, talking to me particularly about it, because I think he knew I was interested in obstetrics, and you just couldn't. You can't believe we'd be in that position again, honestly.
Yeah. It's pre-Roe, for what it's worth, it was pretty much a state decision, and so I began my education pre-Roe, and but it was New York State, and then it was Ohio, and when Roe went through, that didn't register on my meter at all. It was, I don't recall there being one conference about it. So it's interesting to see how this is going to move forward.
It doesn't.
Massachusetts, I think, is pretty inoculated. So I think it at the moment at least is something that is going to be a state by state thing. Okay, and with regard to other things, you have been. Essentially, in what amounts to a multi-specialty group practice, you have been in an academic practice for your whole career, and a lot of changes have occurred with regard to managed care and various insurance schemes that have come up over the years that have been tried one way or another, and then the rules change. And you spoke about algorithms, and a lot of those involve the way the system works. Do you feel do you have opinions about that? Do you feel like your particular situation kind of insulated you from it? How does that go?
Massachusetts is the best place. Places like Massachusetts where every pregnant lady has coverage,
Yeah.
no questions asked, right? Like when I talk to people at meetings and they're like, oh, well, we can't do that because these patients have no insurance. I'm like,
Yeah.
that's just terrible.
Yeah.
So I have to say, I do have vivid memories. Like there's some things you just can't forget. When I was interviewed for medical school, the person asked me about what I thought about national health care.
Yeah.
I did then, and I still think now, is
Yeah.
the best model. And I don't know what specific model, but I think that is the best model, better than what we have here now. And I remember vividly what he said to me is, don't ever say that again. Because you will not make it through medical school. You won't, like, whatever. It was like a kidding threat. And it's true. Like the United States medical institutions are just totally against, to me, what is obvious. Like, you know what I mean? I if you looked at it, without glasses on, you would see it is so much better. And I think COVID sort of, again, just proved that the countries that have nationalized healthcare do better. So yes, if you ask me, have I ever practiced under a national health service? No, I haven't. But all the other schemes that they've come up with, they just all how to pay for it. It doesn't really change the availability of the healthcare, which is really what I think the United States problem is, the availability of healthcare.
Okay. Comments regarding, residency today, practice today, that sort of thing,
Well, you haven't mentioned, and I know you have an interest in it, is the EMR, right? The electronic medical record. So when you said things that change, that is like HIV, one of those things that has changed, dramatically. So I have vivid memories, and the fellows laugh at me and the residents when I tell them, like, you know what, you can complain about the electronic medical record, but at least you can find the electronic medical record. Like, they don't remember that when we used to do rounds in the morning, one of the challenges was to find the chart so you could read what happened overnight, because some nurse had brought it to some place and you couldn't find it, and it was just all ridiculous. And so that has changed. What I would say about that, and I do say this all the time, is that the electronic medical record, the medical record is meant to be communication between physicians. That's my opinion. That's the way I was brought up, go under paper. It then became a medical legal document so that when you went to court, you could prove that you didn't have malpractice. And now I think, and I just had this morning, had a whole hour worth of compliance to know how to bill. It has become this mechanism for billing. And then we add now that the patient can see it. And so now I'm no longer communicating with a professional, I'm communicating with the patient through it. Which, again, nothing is good or bad in and of itself, except that it precludes the conversation that I think is so important of taking care of the ongoing care of a patient. Now is when I read notes of the residents, they're long, has everything in it. Like, I'm sure it's going to be billed to the nth degree, but for the life of me, I cannot find out what happened during that visit. There's no patient voice in it. It doesn't say, and the patient said, there's nothing that helps me know what happened. But it's compliant, right? The billing is wonderful because it has the eight system review, whatever that is, which we're really about today. But it doesn't. And I'm trying. I mean, I know that this is the way it's going to be, and you can't fight City Hall. You know what I mean? I understand, but I feel like that's the patient voice in medicine. I think. You want to hear the
narrative is lost. The thought process is lost. The uncertainty is lost. You have to finish with a diagnostic code when you're not even sure.
Right, and it's all templated, right? So every note looks the same, so I can't tell exactly what happened. So no, that to me is my. As far as if you ask about frustration, I think that, and I think me and most of other physicians, is the frustration of the electronic medical record. But I probably am I'm frustrated in a different way because I'm going to say this, and I have a copy of the ACOG prenatal care. Remember that piece of paper that had you fold it on itself, right? And so that was all you could write on a prenatal visit, like even as an MFN. And so it was just a continuation of like, patient did this, something happened here, something this. But you didn't start with everything that ever happened. Like you weren't talking about first trimester, whatever, that the patient was nauseous when she was now 30 weeks, because it was just a little, that's all you had to do. And I feel pretty strongly that that was fine documentation.
Oh, yeah. I totally agree. I think that when it comes to communication, if you want to communicate with someone, you have to be sharp and brief. And the electronic medical records, as currently configured, because, as you say, that they have placed a priority on billing, and so those sorts of things have perverted the system. You're right. It can be done better. I don't know that it's inherent to the concept of electronic medical records. One comment that someone made very early in the game that I think of often is he said that you need to have a record that thinks the way doctors think, that goes in the order they go in, that thinks the way they think, because if you knock them off their routine, they lose their place. And, they may forget to do something they otherwise would have.
Right.
It derails their thought process. And so the EHR should be a tool to make things easier. And in the rest of our lives, I would say that in general, the electronic age has, by and large, made our lives a little easier. They're convenient to use, they're user-friendly. And we have not experienced that with the electronic health records. So we will see how that evolves. That is to be continued.
It's getting worse.
Yeah. Wow.
Well, the billing thing is getting worse. Yeah,
that's too bad. So we've really covered your career, start to finish here, I think, or not finish, start to this moment.
Here.
And you've also assumed some roles within the department, within, just managing the obstetrics. How does that go?
Those are some of the most satisfying, I would say, like being the medical director of labor and delivery was very satisfying. Because you get to build programs, you get to have a vision, I would say, and sort of, implement that vision. Plus, I really like the fact that it's interdisciplinary. So like, what I love about labor and delivery, and always have loved about labor and delivery, is that you need the pediatrician, you need the anesthesiologist, you need the obstetrician, you need a whole bunch of people, you need the PCAs, you need everybody to be able to do it. And I sort of am a team kind of person. So I really enjoyed that. I did. I would say and then I'm a division chief. And I would say that's supervising people is always a little tricky. I have a very good team. But that's always a little tricky, but I find that satisfying too. Those two parts of my job I find, and then the fellowship, which is sort of like an extension of my division. That had been something that we had worked towards for a very, very, very long period of time, and is finally, we just graduated our first fellow this year. So we're 3 years in.
Yeah, nice. And any final comments for this interview?
Well, I always just finish, and everybody asks me, like, I love what I do. Like, I love it. And so I'm not like one of those people who said, I would never let my child become a physician. None of them have, neither of them have. But I mean, I love what I do. I'm not really, there's frustrations. I think there are frustrations, but in the end, caring for a woman during her pregnancy and then being there for delivery is a privilege. And I'm always great on call. Like, yeah, it's 2 a.m, but it is a privilege to give somebody their baby, to help the baby be born healthy. And even the ones that aren't born healthy are sometimes more satisfying, because like I did a cesarean section just today, and it was a woman who had lost a baby. She told me as after the spinal was in and we're waiting for the spinal to work, she told me, she said, last year this time I had lost my baby, and I had sort of known it was in August, but you never know if you bring those things up. Right. And this is like just the best. Like, you just can't. There's nothing that's better than that, because she had a healthy baby boy, and it was a wonderful day.
That's as good as it gets.
Yeah. Yeah,
Thanks for the interview.
you're welcome. And it's always good to talk to you.